This unit discusses the particularities of occupational therapy workplaces as they relate to the risks for violence. Given the paucity of information available about violence specific to OT work environments, the information provided in the previous units of this module was gleaned mainly from the nursing literature. Of course, that information is, in the main, applicable to other health professionals, including occupational therapists. However, the scope and nature of our practice does differ from that of nursing. OT is a distinct profession with specific and unique workplace risks and hazards. A handful of scholarly OT specific articles is drawn upon, and that material is augmented with information reaped from interviews with 6 Alberta-based occupational therapists from a broad array of practice settings. Also interviewed were representatives from Alberta Health Services and the Health Sciences Association of Alberta. Of course, the contemporary definition of violence in healthcare workplaces, as presented in Unit 2, applies to all settings in which occupational therapists provide both direct and indirect healthcare, including in the exercise of administrative, management, academic, and other functions. Sources of violence also remain essentially the same, though possibly in different frequencies and proportions, and with a few additional nuances. With respect to sources of violence, therapists interviewed for this presentation indicated that violence initiated by patients, for example, those with brain injury, dementia, and some mental illnesses, are most often physical in nature and occur infrequently. 4 of the 6 OTs interviewed for this project reported having either experienced or witnessed violence initiated by patients or members of their families, but only very seldom. They reported being comfortable with understanding, anticipating, and managing this type of violence through the use of their clinical and communication skills, and generally viewed this type of violence as unintentional and not necessarily in the control of the perpetrator, but rather as part and parcel of his or her illness or disability. They felt that reporting these incidences to the treatment team was important in order to develop collaborative strategies for management of this behavior, particularly if there was a risk that patients might be a danger to others. They did not consider these as necessarily needing to be reported to management unless the danger of injury extended to society in general. Violence initiated by family members or visitors, though also infrequent, was reported as being more difficult to anticipate and required the solid support of one's organization. Reporting and managing policies, pardon me, Reporting and management policies and procedures were considered essential in these instances. Hans finding that feelings of confidence in managing patient and visitor violence depended significantly on the organizational attitude towards violence was echoed by all persons interviewed for this project. They generally felt that if the workplace culture is supportive, collaborative, and respectful of its employees, patient visitor violence is manageable. Recalling the study by Durkatz et al., 30% of their 600 respondents reported receiving threats of violence, and that these threats were mostly related to assessment and intervention outcomes not being accepted, and more likely to come from family members. 2 of the 6 therapists interviewed reported receiving threats, including one of a sexual nature and another of stalking from family members or of patients. With respect to colleague supervisor violence or vertical violence, though it is widely discussed in the nursing literature, no OT based studies were found that address this topic. However, interviews conducted for this presentation revealed that, as reported in the nursing literature, this source of violence is unfortunately all too common. 5 of the 6 therapists reported that this type of violence is the most distressing and most difficult to deal with. Misunderstandings about occupational therapy skills and scope of practice, sometimes culminating in lack of acknowledgement and respect for one's contributions, was reportedly fairly common. For example, according to one interview participant, OTs are often at odds with the rest of the team regarding a patient's treatment progression or discharge status. There is thus often pressure to say patients are ready for discharge when the therapist is aware of reasons, usually cognitive in nature, why discharge is not advisable. Psychological fatigue sets in when one's assessment findings need to be constantly defended rather than accepted on their face. The OT in this case compared the scenario to a bucket that gradually becomes overly full, resulting in feelings of harassment and disrespect. According to the Registered Nurses Association of Ontario, the lack of ability to practice to one's full scope, possessing little control over one's day to day work, and the absence of healthy team functioning can result in a work environment in which worker to worker violence is more likely. The lack of participation in decision making with respect to one's day to day practice, if it was constant and ongoing, was also specifically identified by interviewees as problematic. A very pertinent example was the development of safety and security policies following a violent episode without including frontline professionals in the planning. This resulted in a lack of trust and confidence in management. OTs in Alberta have lower per capita rates than all other regulated health professions in Canada, as well as other countries with similar healthcare systems, including the UK, Scandinavian countries, Australia, and Germany. High workloads and constant demands to do more with less has been shown to result in feelings of harassment. One therapist reported being ordered to alter her assessment protocol for a specific patient group against her best professional judgment in order to save time and to shorten the wait list. There was a sense that the integrity of the profession was devalued and that OT had somehow become a McDonald's service, deprived of the time and space required to do their job according to best practice and ethical standards. Studies have demonstrated that these forms of psychological violence challenge one's feeling of self worth as well as one's professional status and standing at work. Profession specific support and mentoring may strengthen professional identity and mitigate the likelihood of succumbing to these repercussions. As previously mentioned, none of the OTs interviewed saw patient visitor violence, particularly if it was physical in nature, with the exclusion of sexual assault, to be significantly problematic. They reported that good clinical and communication skills were by and large sufficient to deal with it. They felt that violence should be reported to the team if there was danger to others or to the public, so that strategies could be developed collaboratively and policies put into place to deal with subsequent occurrences. They stressed that frontline professionals should be included in the development of such policies and potential redesign of workspaces. They spoke of the importance of students being adequately prepared both during their time at the university as well as with fieldwork preceptors to deal with violence appropriately. Three respondents employed in community practices and working with homeless and or persons with mental illness spoke of the importance of reporting to the police. They stressed that the police are there to help and are, quote, part of the team. One therapist reported designing her own working alone policy that fit her rather unique work context. Her supervisor was happy to see it and to approve it. All interviewees felt that patient visitor initiated sexual violence, particularly if intentional, should be reported directly to the police. None reported experiencing colleague or supervisor initiated sexual violence. Violence perpetrated by colleagues and managers or supervisors, usually psychological in nature, was reported as being far more problematic. 5 of 6 persons interviewed stated that reporting its occurrence had not been helpful. One respondent stated it was easier to, quote, leave the job. Fear of negatively influencing one's career was also stated as a reason for not reporting harassment or bullying. Another respondent said that she would not place herself in a position of possibly enduring negative repercussions, such as not having vacation and education time approved, or having a letter on her personnel file, of being excluded from relevant meetings, or simply being ignored by her manager. Most respondents felt it was best to, quote, keep your head down, not rock the boat, and choose your battles. All but one interviewee said the reporting system is clear and accessible, but that managers in place do not appear to have the competencies to carry through the process, and that reports do not seem to get to the next level. One respondent stated that it is, quote, all well and good to have policies and procedures, but you have to follow them, unquote. Another respondent stated that she chooses to not fuel the fire, unquote, by avoiding work colleagues that tend to bully, acknowledging that this might impact client care. She stated that from both a professional ethics and a self-care point of view, this is the best she can do. Other reasons for not reporting include fearing that the incident may be viewed by employers as negligence or poor job performance. Clearly, these findings are worrisome. The reporting of violence is imperative. A, in determining the level of violence experienced by employees. B, for the creation of strategies for immediate and organized responses to threats or actual acts of aggression. And of course, C, for the development of support mechanisms for targets of violence. Interviewees were asked for their recommendations in addressing the problem of violence in the workplace. They suggested that injury prevention and conflict resolution be addressed as distinct topics in educational programs and by employers. They recommended that students not be sheltered or shielded by both the university and their preceptors, and that they be made comfortable with feelings of vulnerability, uncertainty, and asking for help when in doubt of issues related to safety and security. They also recommended that students and therapists be well informed with respect to human rights and labor laws. The following unit will address more formal recommendations for mitigating and managing violence in OT workplaces.